So,
Nisha, welcome, sir. Nisha.
Nisha.
Good evening, dear seniors and residents. So, I'm extremely glad to welcome you all to the PG Club organized by IAP Kottayam. So, this event was actually planned on last Monday, Thursday, but due to some difficulties, we had to postpone this session. Today, we will be planning OSCE sessions in pediatric cardiology and respiratory medicines. So I would like to welcome our IAP Kerala President, Riyaz sir. Welcome you, sir. We have the Secretary, Dr. Gobi Mohan sir also. I welcome sir also to this. Now the PG Club coordinators, Dr. Mohandas sir is here. I welcome sir. And today's faculty, I would like to welcome our faculty for today. Dr. Veerendrakumar sir. Sir is a professor at Travancore Medicity. And Dr. Jayaprakash sir. Sir is the superintendent of ICH. Welcome, Veerendrakumar sir and JP sir. I can see many eminent professors joined today. Dr. Srinivasan sir and my teachers, Dr. Purushothaman sir, Dr. Anandageshwan sir, Laila madam. I welcome all to the meeting. And I extend my welcome to Dr. Thomas Varghese, who is taking charge of the PG Club, and who is the coordinator, and he's very well conducting the program. And also to our journalist Sebastian sir, who is behind the Zoom despite his health problems. And I welcome all the residents, all the faculty from the medical colleges, and also the practicing pediatricians who have joined us today. So all the best. Welcome you, each one of you again. Thank you.
Riyaz.
Riyaz, sir.
Yes. So, respected senior teachers and the faculty for the day, most respected Veerendrakumar sir as well as JP sir. So, this session we are again having OSCE. But we are actually having a combination of different types of PG teaching methods, and it's going on very well. This particular session, I just want all of you to tell about the PG Students Congress, which we are planning for next month. The date we have fixed as June 7th. The program will be held at SAT Hospital, which will be hosted by IAP Trivandrum in association with the Department of Pediatrics. So I request all the esteemed teachers to ask their PGs to register for the program. So this Monday, we will have a Zoom meeting of the medical college faculty group to discuss the nitty-gritties of the Congress. So this is the one message I want to give to everyone here. So with that, I once again congratulate the Kottayam branch as well as the Mohandas sir and team for the state coordinators for taking up this program in a grand way. And I hand over the mic to Nisha to continue the program. Thank you.
Thank you, sir. Now I would like to hand over to our PG Club coordinator, Dr. Thomas, please.
It's already
Thomas
7:40. Can
Thomas
we?
ഗ്രൂപ്പിൽ ഇല്ലാന്ന് തോന്നുന്നു അല്ലേ? Thomas out ആയിരുന്നു.
I think we can start straight away.
ഉണ്ട്. Thomas co-host.
7:40.
So I invite Dr. Veerendrakumar sir to start the first session of OSCE.
ഒരു മിനിറ്റ് സ്റ്റുഡൻസ് റെഡി ആണോ എന്നൊന്ന് ചോദിച്ചേക്കണേ. സാറ് വിളിക്കുമ്പം they should answer.
Okay.
സ്റ്റുഡൻസിന്റെ പേരൊന്ന് പറഞ്ഞിട്ട് അവര് വീഡിയോ ഒക്കെ ഒന്ന് ഓൺ ചെയ്തിരിക്കാൻ പറയും.
Yes, yes.
Okay, sir.
So,
You.
at the onset, express my gratitude to Dr. Riaz, Dr. Gopi Mohan, Dr. Mohandas, Dr. Ananda Keshavan, Dr. Thomas Varghese, Dr. Nisha, Edwin, and Dr. Shari for giving me an opportunity to make this OSCE. In the beginning, this is my OSCE questions are based upon pediatric cardiology, but I am not going into details into the domain of the pediatric cardiologist. My questions are purely from pediatrician's perspective, and the topics are common pediatric cardiology topics that will be asked in the examination. So altogether, I have 8 questions. I will limit in the time. In the time, I will finish the discussion by 30 minutes time. 30 minutes is my allotted time. Hope students are ready. First question will be to Dr. Sanishma, second Srilekha, Nittu, and Shalia. These are they are the students. Hope they will answer it well. So we will start with the first question. First question to Sanishma. First question is based upon 3 images are given: image A, image B, and image C. The images are given of a toddler, 7 days fever, irritability, and above findings on the examination. What are the findings in image A, B, and C? And what is the provisional diagnosis? Sanishma.
Sir, in this page, there is one figure showing non-correlate conjunctival ingestion. Then there is an image of periangle desquamation. Then there is hyperpigmentation of nail, that's chronomycia, and erythema around the BCG scar of the cell, probably Kawasaki disease.
Okay. First, what is the name of the first finding, clinical finding? There is periangular desquamation. In the first finding, fingertips, there is periangular desquamation. What is the color change in the nail? The distal half of the nail has a color change.
The orange chronomycia.
That is called orange brown chromonychia. That is a new clinical sign of Kawasaki disease. And it is seen in 60 to 80% of children with Kawasaki in the first week. Orange brown chromonychia. Second slide B, conjunctival congestion, non-purulent. Not purulence also is there. BCG erythema. So diagnosis is obvious. Kawasaki disease. Kawasaki disease has a diagnostic criteria: fever, 5 days fever, and 4 out of 5 other signs should be there. Now the duration of fever has reduced to 4 as per the current American Heart Association guidelines. If diagnostic criteria is not met, how will you evaluate? That is the question.
Sir, in case of incomplete Kawasaki disease, we have to take into consideration if the child has fever for more than 5 days and compatible 2 or 3 principal criteria, or in an infant with fever for more than 7 days without other explanation, then we have to assess the lab criteria. Mainly it is ESR and CRP. And then if the ESR is less than 40 and CRP is less than 3, then we'll serially look for any serially evaluate the clinical and lab criteria evaluation, that if the fevers persist, and echocardiogram if there is evidence of periangle peeling. And on the other hand, if ESR is more than 40 and CRP is more than 3, then we have to look for anemia for age, total count more than 15,000, platelet count more than 4.5 lakh. If the fever persists for more than 7 days, then elevated ALT levels, albumin level less than 3, and urine WBC more than 10 high power field. Coming to the echocardiogram, we have to
the echocardiogram findings we look for are Z score more than Z score of left descending coronary artery and right coronary artery more than 2.5, and then decreased left ventricular function, mitral regurgitation, coronary artery aneurysm.
Okay, very good. If the ESR and fever more than 5 days with irritability, prolonged fever with irritability, we can suspect Kawasaki. But if ESR and inflammatory markers are low, CRP less than 3, ESR less than 40, then coronary dilatation. If coronary abnormalities is there, you can treat as Kawasaki. If ESR is inflammatory markers are elevated, as you said, total count, platelet count, anemia for the age, albumin, etc., will come into play. Transaminitis, SGPT elevation, and sterile pyuria, microscope, WBC is more than 10 per high power field. Okay, that is the way you have to evaluate. State any two prediction or prognostic scoring system. Scoring system for IVIG resistance.
Sir, for IVIG resistance, Kobayashi scoring system. This is the most widely used scoring system. It has high sensitivity and specificity. However, this criteria was actually stipulated for the Japanese population, and in non-Japanese population, it's not so accurate. Then the other one, EGAMA.
IGAMI criteria. There are two criteria. 4 criteria are there. Kobayashi, EGAMA are good criteria with 70% sensitivity and 86% specificity. Okay, there are different points in that. In EGAMA Kobayashi criteria, you have to get total 11 points are there. You have to get 5 points or more. In the IGAMA criteria, you have to get 3 points. Total 6 points are there. That is the scoring system based upon that. What is the role of doxycycline and ulinastatin in Kawasaki disease?
These drugs improve.
There are drugs which has some role in the prognosis of coronary artery involvement. If coronary artery involvement is there, these drugs has a role.
They improve coronary outcome by a T cell inactivation. They act on the coronary elastin and the increased coronary outcome by causing T cell inactivation.
Yes, doxycycline and ulinastatin. Ulinastatin is a newer drug which has anti-inflammatory activities. It can be used in pancreatitis, can be used in burns, so many other inflammatory conditions. Also, ulinastatin can be used. Ulinastatin is a glycoprotein. It's a protease inhibitor in the urine. Can be synthetically manufactured also. It's a serine protease inhibitor that inhibits the matrix metalloproteinase. That protease inhibitor is ulinastatin. Doxycycline also has that protease inhibiting action. T cell suppression, macrophage production of tumor necrosis factor action on matrix metalloprotease also will be inhibited by these drugs. These are anti-protease, ulinastatin and doxycycline. So that is the role for that. Can you change the slide? Next slide. AP sir, next slide.
Yes.
This is the enlarged picture of that fingers. Periangle desquamation is there, and also orange brown chromonychia, that color change in the distal half of the nail. Yes, next. This is question number 2. This is an X-ray. What are the findings in the X-ray and possible diagnosis?
So, in this X-ray, the lung fields are only giving.
Yes, question is to Dr. Srilekha.
Sir, hello. Sir, in this X-ray, when we look at the lung fields are only giving. And when you look at the shape of the heart, it has got a boot-shaped heart. So it's suggestive of tetralogy of Fallot. And
Okay. Any other finding in the X-ray?
there's a right side aortic arch is seen in this.
The trachea is shifted towards there is a notch in the trachea. If you trace the trachea down, the trachea has a notching towards the left. That is the indentation by the aortic arch. So boot-shaped heart, polygamic lung fields, and right-sided aortic arch. What are the possible diagnosis is tetralogy of Fallot. That is the most common cause, polygamic lung fields and boot-shaped heart. Typical ECG findings in a tetralogy of Fallot. Srilekha? Dr. Srilekha?
Sir, in the ECG, in tetralogy of Fallot, there will be a right ventricular hypertrophy. So
I cannot hear well. Louder, please. Typical ECG changes in tetralogy of Fallot.
Sir, in the ECG, in the tetralogy of Fallot, we get a right ventricular hypertrophy. So there will be right axis deviation and the features of right ventricular hypertrophy. Sir.
Third, one more finding: right ventricular hypertrophy, right axis deviation, RV predominance is there. Then what is another finding?
Early transition in
Due to the RV remodeling.
There will be early transition.
Early transition. V1 will be in the chest leads. V1 will be tall, or V2 will be DPS. That is the early transition in V2. What are the different indicators of severity in a Fallot? Clinical severity.
So
What are the different indicators?
The early onset of cyanosis.
Early onset of cyanosis is?
There is recurrent episodes of cyanotic spell.
Cyanotic spell is not a severity. It can occur in mild Fallot also.
If there is a soft systolic murmur on examination,
yes, murmur is inversely proportional. Softness of the murmur, the lesion will be severe.
On auscultation, there is an aortic ejection click. Yes.
Why aortic ejection click is a severity? When pulmonary blood flow decreases, more blood goes from the right ventricular output, more blood will go to the aorta. So aorta dilates, and that dilatation means more blood is shifted to the aorta rather than the pulmonary artery. So you will get a aortic ejection click. Okay, then this X-ray finding also is a severity. Right-sided aortic arch is associated with the severity. Then what are the ECG findings suggestive of ECG? X-ray is this ECG, severe right axis deviation in the ECG. Extreme right axis also is a severity. Squatting episode is severity, not cyanotic spell. Squatting episodes are severity. So clinically, squatting episodes, early onset cyanosis, softness of the murmur, and aortic ejection click. Extreme right axis in ECG, right-sided aortic arch in X-ray. So they are the indicators of severity. 2 drugs used for the prevention of complications in GOF. Important 2 drugs.
First one is
for the prevention of complications.
First one is propranolol. So it is used for the prevention of tech spells. And second one is iron.
Iron, yes. Iron decreases anemia. Anemia exacerbates cyanotic spell also. Which, there is pulse oximetry screening for newborn. That is a part of the newborn screening.
Yes.
Which congenital heart diseases are less sensitive in pulse oximetry newborn screening?
Tetralogy of Fallot, coarctation of aorta, when Epstein's anomaly, and in interrupted aortic arch.
Why coarctation of aorta? Yes, you are correct. Left-sided obstructive lesions will not be detected by oxygen saturation. For that, pulsatility index you have to look. Pulsatility index less than 0.7 in the newborn period. Left-sided obstructive lesions can suspect. So that is why coarctation and interrupted aortic arch are less sensitive. Which are the CHDs with high prevalence rate, recurrence rate?
That is
The congenital heart disease incidence is only 0.8 per thousand, 0.8%.
hypoplastic left heart syndrome. It's one. Then
Hypoplastic left heart syndrome. Yes, it has a high chance of recurrence. Almost 19% recurrence. Yes.
and coarctation of aorta has a high chance.
Coarctation of aorta. Yes. 9% recurrence. Then
Epstein's anomaly has a high chance.
Epstein's anomaly also has a recurrence chance. Question to JP, can you next slide you can take. No, next question, not next question, next slide. So the answers are ECG is shown. Oh, that is a question only. Okay. Thomas has sent the question only slides. Okay. This is a 6-year-old girl with 1 week fever and antalgic gait. And above findings. Antalgic gait, painful gait, 1 week fever, and the above findings. What is that? Question is to Dr. Nittu.
Thank you, sir. So there are nodular lesions which are seen over the extensor aspect, which could be the subcutaneous nodules. And given the history of fever and antalgic case, the most probable diagnosis will be a rheumatic fever, acute rheumatic fever.
What is the significance of subcutaneous nodules?
The subcutaneous nodules, they has got a strong association with development of carditis, incidence of carditis.
Carditis risk is more, and the chance for carditis is more, and the carditis will be severe carditis if subcutaneous nodules. Subcutaneous nodules are not only seen in rheumatic fever. There are other conditions you can get similar nodules. Certain infections like tuberculosis, syphilis, and other collagen diseases, dermatomyositis, SLE, polyarthritis nodosa, then annuloma granular, deep subcutaneous annuloma granular or deep annuloma granular, similar lesions can be seen. Rheumatoid conditions, other rheumatoid conditions, as already I have said. What are the other predictors of severity in rheumatic fever? Other predictors of severity?
Sir, involvement of 2 or more valvular lesions, then congestive cardiac failure,
Yes.
cardiomegaly, clinical pericarditis. These are also having severe.
Yes. Pericarditis, it is a pancarditis, but clinical pericarditis, pericardial friction rub, if you hear, it is a severe carditis. Cardiomegaly, congestive cardiac failure, 2-valve disease. 2-valve disease also is a severity. Subcutaneous nodules is a severity. What ECG conduction problem? Very common conduction problem is prolongation of the PR interval. Which ECG conduction problem is very rare in rheumatic fever?
Sir, third degree.
Third degree heart block. Yes, third degree heart blocks. Next slide. Yes, 2 more questions regarding rheumatic fever. Rheumatic fever, echo diagnosis is there for the valve involvement. Subclinical carditis can be detected by echo. The echo findings will show that this valve lesion is acute. That is, carditis is acute valvulitis. What are the acute AV valve changes in echo in rheumatic fever? Acute AV valve changes. Because there are certain, if there is a chronic valvular change, lesion, chronic rheumatic heart disease with established valvular changes, there are different findings in the echo. In acute valvulitis, what are the findings?
So, mitral valve being the most common valve affected.
Yes.
The findings are annular dilatation of the valve. There is elongation of the chordae and anterior leaflet tip prolapse. Chordae can also get ruptured. And also there is focal nodularity seen in the leaflet.
Yes, beading. Yes, beading. So dilatation of the annular valve, annular ring, elongation, rupture of the chordae, prolapse of the tip of the anterior mitral leaflet, and beading. Nodularity. rather than thickening of the valve. Fusion, commissural fusion, calcification, thickened valves are usually in established valvular changes. What is tertiary prevention? You know, primary prevention, secondary prevention. What is tertiary prevention? Preventing rheumatic fever is primary. Once rheumatic fever occurred, prevention of the recurrence is secondary. What is tertiary prevention?
Tertiary prevention is defined as the prevention of development, progression, and exacerbation of complications of rheumatic heart disease.
Very good, very good. Progression, complications are treated by the tertiary prevention, congestive heart failures, arrhythmias, etc. Infective endocarditis, they are the tertiary prevention. JP, next question. Fourth question is ECG. 11-year-old boy underwent a certain surgical procedure for giddiness. What are the findings in this ECG strip which strike your attention? What is the cause for this?
Good evening, sir.
So, Shalia.
Yes, sir. Good evening, sir. Sir, a white QRS complex can we see?
Yes, white QRS. Okay.
Then P wave is not always being followed by QRS.
Yes, very good. Chaotic P waves. P waves
Then
that small humps are seen at different intervals, not related with not in relation with the QRS. Wide QRS, chaotic P waves.
Then the vertical lines are pacemaker potential, sir. So
that is
child has had a pacing.
Pacemaker potentials are there. These are the vertical lines before the wide QRS. Every wide QRS, there is a vertical line that is not artifact. That is the pacemaker potential. The cause of this is pacemaker. Yes. Next question is the time over? Shall we go to the fourth question?
Yes, sir. Yes, sir.
Okay. Next, fifth question. This is an adolescent girl underwent a medical checkup for joining a college. Child is not symptomatic. This ECG was taken. List out the abnormalities in this ECG and what is your impression from the ECG? Lead 1, lead 2, lead 3, then AVR, AVL, AVF, chest leads P1 to P6.
Well, lead ECG, lead 1, P and R waves are negative. Then AVL also, P and R waves are negative. AVR, P and R waves are positive. Then chest lead, there is R wave progression.
Yes. Yes, the findings are okay. What is your impression?
Wrong lead placement.
Very good, very good. So, lead placement is not correct. Right arm lead on the left side, left arm lead on the right side. That is why there is progression. Okay. Question number 6. It's also almost the same. 12-year-old boy taken for chest pain. This ECG is taken. Question to Dr. Netu.
So this is a standard 12-lead ECG, and ECG is showing normal sinus rhythm. On looking at the axis, there is negative QRS in both lead 1 and AVL. So it's an extreme axis deviation. Then, in additionally, there is negative P wave and QRS and T wave in lead 1. Also, similar findings, negative P wave seen as AVL and a positive QRS complex in AVL. And when looking at the chest leads, the amplitude of the R wave is decreasing. There is a non-progression of the R wave.
Okay, very good. Just as the previous ECG, lead 1 is negative, AVR positive, AVL negative. But chest leads are not progressing. In the chest leads, QRS not progression. So it is dextrocardia, not change in the arm leads, error in the arm leads. Okay. Question number 7. That also is an ECG question to Sri Lekha.
Yes, sir.
ECG is a 2-year-old malnourished child with diarrhea and weakness. This ECG was taken. What are the abnormalities in the ECG? And what is the cause?
So this is a 12-lead ECG with a normal axis, and in the setting of a diarrhea and weakness, so the lead 2, there is a QT segment prolongation and ST segment depression, and also a UAV seen. So the likely diagnosis will be hypokalemia.
What are the value, giant lead verbs seen in V2?
In the lead, there is a QT prolongation, sir.
Where is QT? V2, just lead V2.
V2.
Tall waves after QRS. After S wave, there is a tall wave. What is that? Yes, in the lead 2, you can see there is a ST depression. ST is depression, slightly decreased. The isoelectric point is TP segment. The segment between T wave and P wave is the isoelectric segment. If you carefully look at the lead 2, between T and P,
JP sare ada
JP sir
battery low ya.
JP sir battery low ennu kanikkunnu. ഞാൻ എൻ്റെ battery എന്ന് വിചാരിച്ചു.
Plug in ചെയ്യാവോ സാറേ? JP sare.
Hello JP.
തോമസ് ഒന്ന് വിളിക്കാവോ?
Yes.
Sure.
So you can the lead 2, this TP segment, ST segment is below the TP segment, so it is a ST depression is there, and actually what is seen is the U wave in T wave. This T wave is inverted, and this V2 you see giant U waves, not T waves. The prolongation is not QT interval, QU interval is prolonged. U wave is that interval. Since T wave is depressed, inverted, the measurement, what you are seeing is the QU interval. It is actually not QT interval. So describe all the ECG findings in the order in hypokalemia.
So the initial.
What is the first change that happens is?
Flattening of the T wave. T wave.
Yes. Yes, decrease in the amplitude of the T wave, flattening of the T wave. Second change?
There will be ST segment depression.
ST depression. Third is T inversion. Then comes the U wave. Then comes the
PR prolongation.
PR interval prolongation, and P wave becomes prominent. Unlike in hyperkalemia, P waves become prominent. What is the importance of this giant U wave in V2? Giant U wave indicates that the serum potassium is less than 3 milliequivalents. Very low serum potassium. Okay. Next question. Last question. Last question, JP sir. Last question. 5-year-old boy with nausea and vomiting, blood pressure 140/89. The question goes to Shalia.
Yes, sir. One second.
Mention the important ECG findings here.
Okay. There seems to be a sinus rhythm with the P being progressed by QRS.
Yes.
T wave appears to be tall. Tall T waves with a narrow waves.
Tall and peak. Tall peak.
Tall peaked T waves.
No, it is not the usual configuration of a T wave. T wave is the repolarization phase. So this is tall and peak. Yes. And taller than the preceding
QRS. So hyperkalemia can be a possibility.
hyperkalemia
Yes,
is
wide
there.
MI can be considered.
So what are the changes in hyperkalemia in the order? As in hypokalemia, what is the order of changes in hyperkalemia?
Tall T waves will be seen
Tall T
initially.
waves, that is the first change.
Then later on,
By what level,
flat
serum level of potassium, P wave becomes tall.
6.5.
5.5, above 5.5 up to 6.5, tall T wave, tall peaked T wave. Tall peak means T wave more than 1/3 of the preceding R wave or more than 8 millimeter.
Then later on, there will be flattening of the P wave, later absent
Yes,
P wave.
second is the flattening of the P wave. Third change is
QRS widening can be seen.
widening of QRS. 6.5 to 7, flattening of milliequivalence of potassium, flattening of P wave. P wave will be absent. Then widening of QRS by 7 to 8 milliequivalence. Then other rhythm anomaly, sine wave appearance by potassium more than 8. Okay, very good. My questions are over, sir. Over to JP sir for the next session.
Sir, we are changing the laptop, so it may take a few seconds.
Thank you, Veerendrakumar sir, for this excellent session.
Thank you. Sorry for not able to show the slideshow. The answers are also there. Thomas has actually forwarded the question only side. Answers also I have given.
ഞാൻ തിരക്കിൽ അയച്ചപ്പോഴേ അത് ആ സ്ലൈഡ് മാറിപ്പോയി. ക്വസ്റ്റ്യൻ ഓൺലി ഇത് ഞാൻ സാറിന് അയച്ചു പോയി. ഞാൻ JP സാറിന് അയച്ചപ്പോഴേ മാറിപ്പോയി എനിക്ക്. അതാ
സാറേ വേറെ തോമസ് വേറെ ലാപ്പിൽ നിന്നാണ് കയറുന്നത്, പെർമിഷൻ തരണേ.
സാർ കോഹോസ്റ്റ് ആണല്ലോ.
നിറ്റുവിന്റെ ലാപ്പിൽ നിന്ന്.
അപ്പൊ നിറ്റുവിനെ കോഹോസ്റ്റ് ആക്കേണ്ടി വരും. ഗോപി സാറേ, ഹലോ.
നിറ്റു അല്ലേ? കേൾക്കാം.
ആണോ ഗോപി സാറ്? എനിക്ക് നോക്കാൻ പറ്റുമോന്ന് ഞാൻ നോക്കാം.
ആക്കിയിട്ടുണ്ട്.
കോഹോസ്റ്റ് ആണ്. സാറേ കാണാൻ കുഴപ്പമില്ല. സ്ലൈഡ് ഷോ ആക്കാവോ? സ്ലൈഡ് ഷോ ഓക്കെ സാറേ.
ഓക്കെ. ഇതാ okay, right. We lost some time. We have two scenarios.
സാറേ രണ്ട് ഡിവൈസ് ഓൺ ആണോ? അതാണ് സാറിന്റെ ഒരു ഡിവൈസ് ഓൺ ആക്കാവോ?
ഇത് വേണോ? ഇതിനകത്ത് സംസാരിച്ചാൽ ഇതിനകത്ത് സ്പീക്കർ ശരിയല്ല. എന്റെ ലാപ്പിൽ കുഴപ്പമില്ല. Okay. Small laptop. Right. Okay, we have a 4-year-old girl who has history of recurrent cough and wheezing. That is about 3 in last 12 months, and her mother has a history of asthma. A general practitioner has made the diagnosis of asthma. I would like you to list points to make the diagnosis of asthma in an under 5 as per the 2025 GINA guidelines. The question is to Ms. Sanishma. Ms. Anishma, are you in?
Yes, sir. Yes, sir.
Your question is 4-year-old girl with history of recurrent cough and wheezing. There is 3 episodes during the last 12 months. And her mother has history of asthma. A general practitioner has made the diagnosis of asthma. Could you please list points to make the diagnosis of asthma in an under 5 as per recent 2025 GINA guidelines?
Sir, as per 2025 guidelines, to diagnose asthma under 5 years, there are mainly 3 criteria. One is recurrent wheezing episodes or at least one acute wheezing episode with asthma symptoms in between, and exclusion of alternative diagnosis and timely response to medications.
Yeah, excellent. The 2025 guideline has very clearly made 3 key points to make a diagnosis of under 5 asthma. And it's very important to diagnose asthma in younger children. So like recurrent episodes, like you said, is 1. 2 is no other explanation other than a viral infection at the time of the attacks, and response to SABA or response to a trial of ICS or ICS is most probably you can make a diagnosis of asthma. Okay. So this is what the current guideline says. Recurrent acute wheezing episodes, no likely alternative cause for respiratory symptoms, and timely clinical response to respiratory symptoms, especially with short-term response to SABA, plus or minus oral corticosteroids, or as SABA alone, or even inhaled corticosteroids trial of 2 to 3 months. So this trial has been started on formoterol budesonide combination. Give your comments on MART therapy.
Sir, MART is maintenance and reliever therapy, where we advise the child to start a single inhaler containing inhaled corticosteroid and a long-acting beta agonist. We can use it as a maintenance dose and for relief of symptoms during episodes.
What way it will help the child?
It will reduce the number of exacerbations.
As well as it can reduce the number of oral corticosteroid usage in future if the child is not using that. So the time of an attack, you can use an inhaled corticosteroid plus a SABA, or you can use a maintenance SMART therapy. Both decreases the exacerbations as well as the usage of oral corticosteroids. So as she has elaborated, this combination, formoterol has got a longer half-life. So it both acts as a reliever as well as a maintenance medication. So you have to be smart in treating asthma. So MART therapy is much better, especially older children, adolescents, and it will be a preferred treatment in younger ones in future. So she has been given instructions to reduce risk factors. List 4 common triggers and their antigens, which you would like to prioritize.
Most common is dust mite. And then we have pets. And the common antigens are in dust mite there is DERP2. In pets there is FELD antigen.
So you mean to say that the density of dust mites can be more in a house, in a room, that should be reduced so that the antigenic exposure is to be less. The saliva, the urine, the dander of pets, especially cats, which is more dangerous than dog, it will be a continuous airway inflammatory stimulation. And cockroaches are also well known to induce airway hyperresponsiveness as well as inflammation. So, so this is a young child. It's a young child, Shalia, and older children. So you can say spirometry maybe above 5 years, or some children do it even less, or a peak flow surrogate indirect equipment which can be used. But then what way we can assess lung volume in infants and children below 5 years?
Sir, in below 5 years, forceful breathing can't be taught to them. So in such cases, devices which can help in like to identify with this normal respiration will be helpful. Oscillometry can be
Yeah, pulse
used.
oscillometry is one which is practical, which is being done, which is available, right? Very good.
Then body plethysmography, where lung volume and functional residual capacity can be found
Yeah,
out.
we have certain methods which are sometimes research tools. Sometimes impulse oscillometry is easily available, but plethysmography, then you have raised volume rapid thoraco-abdominal compression, RVRTC, then other techniques which can be used. So we must know that we can actually measure the lung volume like in an older child, but it may be practical in future. Okay, it may be available easily. So we conclude the session on bronchial asthma. Our effort is we should diagnose asthma in a younger child. We should put an objective criteria which is reasonable, even though we have variable respiratory symptoms as well as airflow limitation documentation in older child. Younger children can be diagnosed with a reasonable accuracy, especially 1 to 5 years. So it's better to utilize these available guidelines. So this child is an 8-month-old baby who has got upper respiratory symptoms, cold, cough, breathing difficulty, a 1-day duration. On examination, she had bilateral bronchi and chest X-ray showed hyperinflation. Her SpO2 though not given is 90%. Need to this child has been diagnosed as bronchiolitis. Okay, right? What's the standard treatment for this baby? 8-month-old, SpO2 90%, upper respiratory symptoms, lower respiratory signs.
So as a case of bronchiolitis, I will manage this patient. First of all, start the patient on supplemental oxygenation. Humidified oxygen would be my choice.
So you use heated humidified oxygen.
Yes, sir.
Okay. So
And in case if there is respiratory distress, I'll be preferring HFNC. And still, if it's not improving or worsening, I'll be considering non-invasive positive pressure ventilation.
so heated humidified oxygen, HFNC is well known as a treatment, initial treatment, supportive treatment. It builds a good reservoir. It gives good washout. Okay, good PEEP. So there are so many advantages for using HFNC. But then there are also thoughts that HFNC is being overused for bronchiolitis. A meta-analysis actually underscores the effect of the current efficacy of HFNC as a treatment. So HFNC, very good. Then what else to be done? Any other standard treatment to be offered to a child who has got bronchiolitis?
Ensure that the baby is getting adequate nutrition and hydration.
Yeah, good
Either by
hydration, very vital, very vital. Yeah, child may be losing a lot of water. Insipid water loss may be more. Okay, may not be feeding adequately. So hydration is very important. What's the role of adrenaline, steroids, antibiotics, hypertonic saline? What's your opinion?
the recent guidelines, most of them, they do not recommend routine use of nebulized salbutamol, adrenaline, or hypertonic saline. So those won't be my choice.
Okay, good. So we conventionally used to put some of these drugs, at least hypertonic saline, during a period. Sometimes we had used salbutamol, adrenaline. They're not evidence-based therapies nowadays. So high flow nasal, humidified high flow nasal oxygen If the baby is hypoxic, hydrate the baby. If the baby is not in distress, nothing need to be done. That's the way it should be. Okay. I think this baby has pneumonia, doctor. I have to start antibiotics. How can I decide a young child with distress is not pneumonia? In my days, I've treated it like that only. What's your opinion, Nitu? You have a
If the patient is having high-grade fever, fever of 39 degrees Celsius, and if on examination, if I could find persistent focal crackles, maybe those are suggestive of pneumonia.
Yeah, high 39 degree Celsius fever, then persistent focal. These are nice guidelines, which are quite useful when you treat such babies. So secondary infections are not so common with bronchiolitis, but if you get high fever and say persistent focal signs, then probably you should consider pneumonia and treat accordingly. Okay. So what are the preventive measures? Rileka? How we can prevent it?
So first during the seasons, RSV seasons, we have to limit the exposure to those sick individuals, and we have to maintain a proper hand hygiene so as to prevent the transmission of the virus. And we have a monoclonal antibody, which is Nirsevimab, which is a single dose of this monoclonal antibody can be used, especially in children less than 8 months of age.
Okay, so basic hand hygiene. Okay, limiting exposure to another child who is younger, right? Okay, Nirsevimab, a monoclonal antibody, which has got a long half-life, say 5 months. So it can be used. It can be used in children above 8 months as well. The dose is higher, 100, right? Okay, right. So that is one thing. Okay, what's the role of maternal vaccine? Maternal vaccine, any role?
Yes, sir. A maternal vaccine can be used in the gestation age between 32 to 36 weeks of gestation. We got a bivalent RSV perfusion F protein, which is the maternal vaccine available.
I don't know whether it is available here, but Nirsevimab is available here. Okay. Definitely we have high-risk patients, especially those who are less than 3 months, those who had heart disease, those who have got BPD, those with immune deficiency. In such children, such preterm babies, it could be a good choice. Maternal vaccine, I'm not very sure whether it's available here. If you treat this child and you find it difficult to control symptoms, what are the possibilities are to be entertained?
If the child has any underlying cardiac conditions, like any underlying congenital cardiac disease, or if there is any underlying lung conditions like tracheoesophageal fistula, or if there is an infection with the concurrent infections with the multiple viruses, or if there is any other conditions like bronchopulmonary dysplasia or gastroesophageal reflux disease, in all situations, it's difficult.
I think if a concurrent infection with 2 viruses, common, especially RSV rhino or metabloco, associated congenital anomalies like CPAM could make it difficult. Sometimes a heart disease, which is not picked up, could make. I think the time is up. Time is almost up. And so we had a bronchiolitis case and we had asthma. Thank you, Thomas. Thank you, Riaz, Gobi Mohandas sir, and everyone here.
Thank you, sir. Thank you. It was an excellent presentation. Purushothaman sir, എന്തെങ്കിലും പറയാനുണ്ടോ?
My comment is we have stopped early. There was no need for hurry because we used to continue PG sessions beyond 9 o'clock also. It's the first time you're stopping at 8:30 on Dasale. Yeah. Anyway, both of you did very well. And Veerendrakumar sir, you have left Yoda.
No. I'm here, sir.
Okay, sir. And in the first case of Kawasaki, sir, your last picture, was it a exaggerated BCG response that you didn't highlight, I think.
Yes, exaggerated BCG response. Erythema over the BCG scar.
Okay. And in the
We had a 4 month baby with this exaggerated BCG rashes and a fever, and also skin rashes. And it has coronary involvement also, severe coronary involvement.
Case of nodules, rheumatic nodules. I am first time seeing this much of extensive nodules on your hand and fingers. That's a rare situation. And how many of you are seeing nowadays acute rheumatic fever and rheumatic valvular heart disease? I have not seen, because maybe I have retired from government service and now the cases are less. I didn't see a rheumatic case for the last 2-3 years. So what's about your experience in the government institutions with more number?
No, sir. The number is much less. Much less. We have
Much
not seen a
less,
nodule.
but
Only
still we see cases. And the typical rheumatic fever cases we never see nowadays.
It's rare. It's going down even once in a while only. Annual incidents we need to collect in the state, I think. There are multiple reasons for that. Maybe the bacteriological profile also need to be checked. Or is it because the antibiotics left and right using also is having an action on these rheumatogenic strains? One thing. Srinivas sir is there. He'll have some comments.
I'm there. Excellent questions and very well this thing, and very important areas have been covered. And of course, as you mentioned, Kawasaki, that not this thing, erythema is very wide and this thing. Otherwise, anyhow, I enjoyed it and I learned also a lot. So it's time for me to reread the latest edition, etc. Good. Eye awakening.
So what is the
Thank you.
reference for that Kawasaki DC? Which article is?
Pardon?
The Kawasaki, the reference article, sir, which you said, doxycycline.
That
the
orange brown chromonychia.
Yeah.
Or that I will send.
Is
In
this the
this article in a IJPP, there is two cardiology issues in Indian Journal of Practical Pediatrics. There are two cardiology issues, 1 and 2. In the, I think it is in the cardiology 1, Kawasaki was given a little details. There it is mentioned. I will take the reference. Primary reference, I will take that.
You need that is by Saji, I think. I remember. Dr. Saji was the author, I think, in that pediatric practical pediatrics in the Green Journal. It was the long back. It was in 23 or so, sir, not in 24, a little early.
Because you're just seeing up to date, but nothing was saying. I will be searching anyway. If it is there, it is there in other journals as well.
There have been articles in asthma, no? Vitamin D level is also very important because we have also done in Mahatma Gandhi Medical College thesis for PG group. So many times it is less. Not only it causes stridor, but hypocalcemic, but it's also linked to increased incidence of asthma. And I think it's worthwhile, if possible, to estimate the vitamin D levels of children. What do you think, Dr. Purushothaman and Dr. Veerendrakumar, sir, your opinion?
I don't know to what extent. Anyway, vitamin D is mentioned for each and every situations now.
There are studies that vitamin D is not related with asthma severity. That is what I have read.
in this GINA 25 guidelines, I'm yet to go through. I think it's not considered as a major thing.
Yes, as a predictor of severity of asthma, vitamin D 25 hydroxylase level as a not a predictor of severity of asthma.
Thank you.
The postgraduate students, they have answered very well. Congratulations.
Yes, students did well.
All of them participated and answered very well. Thomas, can we wind up?
Sir. So thank you all. Thank you all. Good evening.
Good night.
Thank you, Thomas.
Good night.
Thank you, both of you, Dr. JP and Veerendrakumar, sir.
Thank you, sir.
The importance of this session was it's more of a pediatric presentation. When we get a presentation from the super specialty, more of in-depth of cardiology will be there. A little bit, the pediatric aspect may not be highlighted. So that's the importance of once in a while bringing pediatricians also in that area. So that is a good method, I think. Riaz and Mondas should consider this thing. There's definitely we should be considering more and more of the pediatric aspect, especially when the cardiologist is handing over the cardiology heart case to the pediatricians. The role of the pediatricians are there before the reference to pick up the heart cases. Then the follow-up case also. So there is a need for the real pediatricians' role knowledge for the management and follow-up of all those cases. So that should be highlighted only if it is done by a pediatrician. So pediatricians' case discussion definitely should be there in the coming sessions also.
Okay. Good night.